So we've talked about the fact that there are a lot of effective interventions that exist, but how do we make sure that we get the right people to go to those interventions? How do we make sure we're reaching them? Because if we don't, we're not going to reduce inequalities, and worse than that, we might even increase inequalities by depending on who does and does not take up interventions. So we've got an awful lot of learning from our community in Bradford. But just to set the scene, Bradford is a big city and district in the north of England, and it has huge levels of disparity even within its one city. So we go from inner city areas with really high levels of deprivation to really rural, affluent areas. There is a 10-year life expectancy from the affluent areas to the inner city areas, and it's less than 10 miles. So we have children that are fortunate enough to grow up, and actually I grew up just behind the trees there, and then a lot of children that are living in these really urban, deprived areas. So Born in Bradford is a research program that it was designed to work in this area to understand what makes children ill and how can we make all children healthier and happier. And we do this through birth cohorts and also designing and evaluating programs to make a difference. So we have 3 birth cohorts in existence at the moment. We have the original Born in Bradford cohort, which has over 12,500 children who are now all in their adolescence. We have BIBS, which is our second birth cohort, which I'm going to talk more about today. And we have a third cohort called BIB for All, which is just going to go on forever, and it just captures routinely collected data on mums. They do consent to that. So the core element of the Born in Bradford cohorts is that we work with routinely collected data that comes from health services, education, voluntary sector, and children's services. And I think we're quite fortunate in England that we have a single kind of system, so we're able to connect all of this together. So families consent for us to follow them and their children as they grow. In BIBS, which I'm going to talk more about, importantly, this also includes exposure to interventions and services. So we know exactly what families have and have not been exposed to. And in BIB and BIBS, this is complemented by really in-depth, rich data. So we really understand the social determinants that are happening in these families. One of the absolute core elements of Born in Bradford that we're most proud of is that we are community driven. So our community, it's not just about engagement or consultation. They actually design our research priorities. They create and set them. They help us with our research design, and they help us to interpret our findings and make them real in the context. And we also have really key relationships with stakeholders so that everything we're doing is relevant to practice and policy. So we do pride ourselves on being a people-powered research program. And what that allows, oh, sorry, yeah, just one final thing is that whereas BIB and BIB for All are right across the areas of Bradford where women give birth at the main hospital, the BIB study is focused on 3 inner city areas where there is extremely high ethnic diversity and extreme deprivation. And the reason why BIBS is focused in these areas is because back in 2015, it received a huge investment of £50 million from a national lottery funded programme to improve things. So again, it's in prevention. So it's from pregnancy to the age of 4 to improve language and communication, improve social and emotional development in children, and improve nutrition and reduce obesity. This is a real challenge for us as evaluators because Better Start Bradford were the commissioners who decided what they were going to implement. They commissioned this out to service providers who delivered this as part of normal practice. And then we're kind of chasing behind everybody trying to evaluate what they've been doing. And just a quick note of why these areas were chosen. It is because there are some really poor outcomes for children right across health and educational development. So really high levels of poor oral health by the age of 5, high levels of obesity that are rising year on year, and low levels of school readiness, so ready to learn when they arrive at school. So BIBS, as I've mentioned, is, as we like to lay claim to, the world's first interventional birth cohort. So it's specifically designed to evaluate interventions that are being delivered in practice through Better Start Bradford. We started recruitment in 2016. We are going to finish recruitment in July 2024. So we've been going for 8 years. So we've got this really broad range of children who have been exposed to these interventions throughout their development. And so far we have just over 6,000 mums and their babies in the cohort. We think it's probably one of the world's most diverse cohorts, perhaps in the high income area. But we have families from all over the world who are taking part in our cohort. We have 88% that identify as an ethnic minority in the UK. Over half of the mums were born abroad. We have more than 90 different countries of birth in the cohort, and I think it's over 60 different languages that are spoken now. And a third of the mums have little to no English language ability. Just a little bit of a more note on the ethnicity. So we have a majority population in this area from Pakistani heritage, and an important Central and Eastern European community there, and a small, but again, very important white British community. And then a broad range of other families, as you can see, that come from lots of different areas across the world. So the question that I wanted to answer today really was, what can this rich data from BIBS and from our working with the community tell us about this community and how they do or don't engage in the interventions that are on offer to them? The first thing that we picked up on quite early on is that these areas were chosen because of their high levels of deprivation. So 84% of these families are in the most deprived decile in England. And yet employment is very high. So it's an economically active community. So in our survey during pregnancy, we asked how well families are managing financially. And we see that there's a vast array of differences there. So the majority are actually living comfortably or doing all right. And then we have this 23% who are financially insecure. So we talk to our community, as we do all the time, about this. And I think that there are reasons that families actually choose to live in these areas. So I know that the first talk today was about, if you live in a deprived area, leave. We kind of like, hang on a second before you do. So we know that, I mean, we talk about in Bradford, we have these families that have multi-generations living in a single house. They're often overcrowded in our sort of British terms of these things, living in small houses. And there are disadvantages to that. And we saw that in the pandemic. So these areas of the city were very sticky. The rates of infection never went down. And we were in lockdown in this for a long time because of this. But actually, families choose to live there because all their family live there. And so they've got all of their social support, and they've actually got this financial buffer by all, living in together as well. So there are benefits that are not necessarily obvious at first sight. And when we look at other vulnerabilities in this population, so we know that 1 in 4 children are late talkers, but actually this is less likely in families, larger households, which kind of makes sense. But, it's a benefit that wasn't necessarily obvious. And in our cohort, we do have very high levels of maternal mental ill health. So a lot of mums, nearly half of mums are reporting some low mood. But this was much less likely in the Pakistani heritage mothers than it was in the white British. So Pakistani heritage mums were reporting 12% clinically significant symptoms, and that was 22% in white British mums in this area. We did a lot more work on maternal mental health during COVID, and we partnered with another area in London, a borough called Tower Hamlets, which has huge levels of ethnic diversity as well. We asked the same questions, and then we could put them together. And actually what we had was this huge data set of ethnically diverse mums to understand what was happening during this time period. And the diagram on the left is, sorry, I was just checking that because I still don't know my left from right, and I'm not going to learn it now, am I? Because my brain's past it. This is unadjusted, and you see some ethnic differences, but once we adjusted for the key factors of loneliness, a lack of social support, financial insecurity, and area where you were living, actually the ethnic difference disappears. And what really we're seeing is the fact that some ethnic minorities are far more likely to experience financial insecurity. They're far more likely to experience a lack of social support. And interestingly, we found that the families that lived in London were far more likely to have clinically relevant symptoms than families that lived in Bradford. And we thought this was quite interesting, and we wanted to explore it more. So we did qualitative interviews with 25 Pakistani mothers of Islamic religion. And we talked to them during COVID, so we were getting their experiences during this very difficult time. But what we found is that, yes, they were experiencing high levels of stress, the same as all of the communities, with that high level of worry and concern and domestic load and difficulties. But they found three core components that they felt really helped to protect them against mental ill health during the pandemic. The first was religious practices and their religious beliefs. So they found comfort and relaxation in their prayer. They also found that relating this experience to their learning and religious belief actually allowed them to put it in perspective and allowed them to cope with it. We found a really key element of social cohesion in these areas. Obviously, this is a majority population in these areas. And they were telling us about how even if they didn't have family around them, their families, their neighbours who were like them were there and supporting them and giving, looking after them. And these were families that had young children, so high levels of anxiety as well. And again, the benefits of living in these multi-generational households where there were people to share the load with, the stress, and more social support. So we wanted to look more at the population that are in these areas. So we did a latent class analysis to see if there were some sort of key groups that were coming out. And we did find 4 groups within this community. So we had a 26% that fit into a non-migrant most advantaged group who tended to be of South Asian origin. So these are second generation or third generation migrants. Good English, well educated, well employed, good financial security, and good mental and physical health. These families, on paper are doing great. And then we have a second more advantaged group who tended to be migrant, and these were from a mixture of ethnic backgrounds, had English as a second language but able to speak it well, had employment in the home, and again financial security and good health. And then we have 2 less advantaged group, one that was non-migrant that tended to be white British, but with low education, more likely to be unemployed and more likely to be financially insecure and have poor health. And a final very disadvantaged group of just 8% of the population, but I think a really important 8%. So again, mixed ethnicities, but less likely to speak English well, high unemployment, financially insecure, and very high levels of poor mental and physical health. So our question was whether these groups actually then was associated with whether these families did take part in an intervention. And I guess a basic assumption might be that those that are doing well might be more likely to attend. These latent classes actually in a regression did not predict intervention participation. But we did find that being from a Central and Eastern European ethnicity and having little to no English language reduced the likelihood of attending a project. Being of Pakistani ethnicity and being socially isolated were more likely. And we thought this was quite interesting. And again, when you think about it, it makes sense that if you've not got much social support, you kind of will want to go out and seek additional help. But just to say with the latent class analysis, obviously with those groups wasn't related to the intervention. So we wanted to understand whether these characteristics were additive rather than interactive. So we used a relatively new regression method, which I wish I'd written this on the slide, but it's multi-level analysis of individual heterogeneity and discriminatory analysis. But what it allows you to do is for the strata that you put in, so for the components, it allows you to, it creates strata for every different possible combination. And it also allows you to discriminate between what's additive impacts and interactive impacts. So this is the predicted probabilities of engaging in an intervention. And you can see that at this, well, you might not be able to see, but trust me, at the top, South Asian and those with low social support, those were the two groups that tended to be most likely. And down at the bottom, we have the Central and Eastern European groups who were far less likely. And when we looked at the odds ratios, again, we see this really important key factors, which we did find were additive rather than interactive. So the more of these you have, the more likely you are, but it doesn't necessarily mean that they're interconnected. We've also looked a lot of, we've done a lot of qualitative research with the families that have gone to interventions to try and understand what, you know, the key components of what they see as the key components to being able to take part and to see a benefit to them and their children. So we looked across some core themes within some perinatal projects, interventions, and we found 3 common themes that were key components for uptake. The first was having a home visit before the intervention started. So actually, it's about the practitioner building that rapport and building a level of trust and safety with the family. We reported that practitioners with community language is not just about the ability to speak the same language, but actually to be able to, because they're trained, they can do, you know, talk to people with empathy and relate to them and make them really sort of feel a part of what is happening. And another one which was interesting was that both practitioners and families reported actually having a choice about whether to take part or not, empowered them and made them want to take part in these interventions. We also looked at the core components for completing interventions once you started them. And these are themes that have come up earlier on, so I was really pleased to hear them again. But the continuity and stability of staff with that ability to build a strong therapeutic relationship and trust, absolutely essential to families. Interestingly, having a person-centered and flexible approach to the delivery. So the core components are the same, but you're able to adapt it to relate to people's needs and to people's cultures and make it make sense to them in their environment. And the perceived need and relevance of the additional support. So really understanding how this is going to benefit them as a family. And recognising a lot of practitioners talked about these interventions filling the gap in between those statutory services, because once your midwife discharges you in England, you'll see your health visitor a couple of times, and then there's this big gap until you see them again. So it sort of feels like it fits into there. So in summary, and I think that this relates quite well to a lot of the other talks today, is that there are multiple different complex levels of both advantage and disadvantage in these inner city areas. And they do appear to be related to specific vulnerabilities or protection from these vulnerabilities. And there are multiple and complex reasons for engaging in and completing interventions. And one size does not fit all. So again, it's obvious, isn't it, about this silver bullet not really fitting there. So this links back to Sharon's talk about the pathways and the fact that we need flexible complementary services to meet the needs of families rather than just kind of picking up a load of stuff and throwing it or expecting families to come to that. So as an example of that, within the UK, we have midwifery, home health visiting, nursery education, which is free for a certain amount of hours when you're age 2 and 3, and school. But if a mum chooses not to go to send her children to nursery, she can't go to nursery. And because she's at home and because she wants to be with her child, and you know, that seems reasonable, that seems fine. But are there other interventions that will benefit that family, teach them about the importance of home learning, give them what they need to be able to give that good sort of development at home? Or are there stacks based on need, as Sharon was talking about, that actually for a family that have a particular set of needs, if they receive interventions that fit those needs, will that help children develop? And this is what I'm going to be spending my next 3 years looking at. So maybe in 2028, I'll come back and share more information on these. So thank you very much for listening.
That was great. Thank you for sharing those ideas and those findings and all of that recent questions and comments. I know it's late in the day.
Yeah.
Silvana.
The composition of your population is absolutely fascinating. And so it seems that you have one of the greatest challenge here in terms of providing intervention to a very, very heterogeneous population. And so how will you do it just in terms of communication with your different groups? The cultural differences between them, and so I guess you will need a very flexible package.
I think the trouble is that this learning is coming at the end of this program. So I think one thing that came early on was the fact that we've discovered that not many, well, a third of women didn't speak English. So you can't just deliver courses in English. You can't just have your information in English. And actually, a lot of the interventions did deliberately employ workers from the common groups within the area. But that still means that there's a huge population that are missing out. And I think one of the drivers in this program was to engage the predominant ethnic minority groups, the Pakistani population. But that I wonder now, and I think that we need to look more at what's happened to the white British and the Central and Eastern European population that look like they're more disadvantaged, and actually, you know, what does and doesn't work for them, because I think that there's a big gap.
Further comments or questions? Yes.
I'm wondering if the answer is one thing we think about a lot when we're thinking about who needs support, is that so much of our system is based on understanding risk. We don't actually do much quality measurement or thinking about family strengths and resilience. And sometimes I think, which is why I actually agree with you, knowing Bradford, about worrying about the white British community, because there's actually quite a lot of community resilience and strength amongst the Pakistani and Bangladeshi families there. And I think we have we seem so worried about capturing people who are risk that we don't kind of say, well, actually, do we need to worry about every one of these risky families? Because in fact, actually, have they got enough good stuff going on that actually we need to manage it? And we're kind of dealing with that kind of idea again, that managing risk is not enough. And this is coming back to Sharon's point about investment. It's not just about stopping bad happening. It's about how do we make good happen? And a lot of families already make good happen. So I'm just wondering if that's actually, because then we bring in strengths-based interventions, but we actually don't understand the communities particularly well in terms of strength. Just any your thought?
I mean, I think that's absolutely right. And I think that had we done all of this and then started to implement the interventions now, I think they would look very different, or they would be designed in a very different mindset. I think we also need to be careful about, it's not everybody is protected. And I think that the vulnerable families within this big group are probably very, very vulnerable, but their voices are not heard. But I really, really feel this sense of we've got such value in learning about the protective nature that actually we should be thinking about interventions on the basis of what we've learned from these families. You know, everybody needs that social support. Everybody needs a financial buffer. And when you have those, even when you live in these areas, or even if you're from an ethnic minority, actually look what can happen. So, you know, you can flip it both ways, I guess.
Did you have your hand raised? Yes, please. 1 minute. Let me get you the microphone, please.
I was, thank you. I'm on a Scarlett from the UK, but working in Paris, on father's mental health. I was wondering the importance of religion for a lot of these people. I'm not religious myself, but I'm wondering if did you consider integrating religion into these interventions, or is it just an absolute no-go? Is there space for that kind of discussion?
I think it's really important. And I think it goes back to that flexible and adaptable approach. So what you're talking about needs to relate to the people that are in that room. Another thing that we do in Bradford is actually we've taken some interventions into mosques and into gurdwaras and into churches, because that's where you will get the majority of the South Asian families anyway, and actually Central and Eastern European families. So not that you want a captive audience, but at least you're going where people are, and if you get people, religious leaders backing, then people will listen as well. So I think I think you're absolutely right. It's a really good point.
Thank you.